a study going on now, and this work has been going on outside the United States for some time, and that work centers on cooling the scalp.
Okay.
So do you know why you'd cool the scalp if you're getting chemo?
To prevent the hair loss?
Why?
Maybe to slow down the cells.
Why?
I don't know. You lost me.
Okay, well, what happens to your blood vessels when you cool them?
They constrict.
They constrict.
Right.
So imagine you have chemo going through your body, and all of a sudden they hit the scalp, and your scalp is freezing.
Okay.
What happens to blood vessels?
So they're going to close down, and the chemo's not going to get there.
Yeah.
Okay. I like that.
It's, things that probably our ancestors 2,000 years ago did. In fact, we know that it's true because for hyperthermia, we use heat to help kill cancer cells. We have a hyperthermia program, and it's been known for thousands of years in the days of Cleopatra that heat would kill cancer.
Okay.
And in those days, they would do molten metal. They would pour molten metal on a patient's cancer.
That sounds intense.
Yeah, so imagine how painful that is. But it helped make the cancer go away. So this is the opposite end of the spectrum. So rather than using physical heat to kill cancer, and then today hyperthermia is not like molten metal. It's a device that sends microwaves into the body to heat the cancer. You can cool the scalp. And doctors have known about this for actually decades.
Wow.
But the FDA never allowed it, and doctors have always been afraid that it might lead to a sanctuary, meaning the cancer cells would go to the scalp, the chemo wouldn't get there, and all kinds of crazy cancers would grow from your scalp. So just now, the FDA has approved a trial, and it's going to take place across the United States for people with stage 1 or 2 breast cancer getting chemotherapy. They're going to cool the scalp. It's a little hat, like a swimming hat, and it's got coolant that's running through it. And while you're getting the chemo is going to hit that roadblock of constricted blood vessels and hopefully keep the chemo away from the scalp. So there are things to do that try to make chemo more appealing. And obviously, not all chemo causes hair loss. Certain do, certain don't, and it's also dose-related. So that's an interesting, hopefully positive step for people not to be concerned about hair loss, but rather than to be concerned about their life.
Sounds like a creative strategy.
Now, here's someone with a lot of hair. Do you know who that is?
It's Angelina Jolie, isn't it?
Yeah, Angelina Jolie. She has a lot of hair there. Wow. And some people say it's pretty. I won't be judgmental. I'm not judgmental. But she was in the news for having prophylactic bilateral mastectomies.
That's right.
So she had both breasts removed. She's 37 years old. She's kind of, I don't know, sexual figure in America, isn't she?
She is. She definitely is.
You're a young man, and is she a sexual figure to you?
She is. I've seen a lot of her movies.
Yeah, and what's the most appealing part of her movies?
It's not the plot.
It's not the plot. Well, she's a good actress, actually.
She is a good actress.
Yeah, she is a good actress. Has done some great movies. Her mother died when she was in the 50s.
Okay.
So she died at a relatively young age, at age 56. And Angelina Jolie carries the BRCA1 mutation. So it's a gene mutation that puts her at a particular high risk for breast and ovarian cancer.
Sure.
And Angelina Jolie went to geneticists, she went to other doctors, and she understood her risk for developing breast cancer was about 85%.
Mm-hmm.
She's not a typical woman, so this information does not apply to women who do not have the BRCA1 gene.
Right.
Because a lot of women are getting bilateral mastectomies without that gene. They're doing it out of fear. We're going to talk about that in a minute.
Mm-hmm.
Angelina Jolie had a prophylactic bilateral mastectomy with immediate reconstruction. We don't know what kind of mastectomy she had. I mean, doctors are doing different kinds of work, and sometimes they actually will do mastectomies leaving the skin intact. So probably if someone sees her and she had her skin intact, you probably wouldn't even know that she had surgery done.
Sure.
Compared to most women who have a mastectomy, a lot's been done. So I would assume that this was all planned in advance, and she probably had subcutaneous mastectomy and implantation immediately, and probably is looking pretty good. But still, she went through the surgery, and she went public about it, and I think we have to acknowledge that she brought a lot of attention to this disease.
She did.
and hopefully will allow women to make more informed opinions and decisions about it. Now, she did not undergo removal of her ovaries,
Okay.
and she has about a 50% chance of ovarian cancer.
Mm-hmm.
And ovarian cancer is a lot more difficult to detect than breast for the reasons you talked about before.
Right. The late diagnosis.
Right. So have you seen women with ovarian cancer?
I have. I've seen a friend die of it, actually.
And it's terrible, terrible, terrible death.
It is.
And it's very hard to diagnose early. The ovaries are deep inside. There are things to do for women. There's cancer marker tests like CA-125, which is used.
Sure.
There's transvaginal ultrasound to look at the ovaries.
Sure.
So women can get testing done if they choose to for ovarian cancer. And again, it's a very difficult disease. So these are issues that you should take up with your gynecologist or your oncologist. What she's going to do, obviously removing the ovaries has systemic effects. The breasts are a local issue. They don't produce any hormones or have systemic effects, but the removal of the ovaries would put her into menopause at age 37.
Right.
So for some reason, she chose not to go after the ovaries, even though the ovaries are more difficult to control if they're cancerous. So I assume it's because of her fear of going into menopause, I would assume, but I can't speak for her, and she didn't address that issue.
Mm-hmm.
The chance of developing breast cancer for her was 87%. It's now thought to be down to about 5%.
Mm-hmm.
There's many women who have breast cancer, random breast cancer. So what we typically hear about, they have breast cancer, and they choose to have bilateral mastectomies. I think Debbie Wasserman Schultz, the woman who's head of the Democratic Party that ran Obama's reelection campaign, is a congresswoman from Florida. I believe she had bilateral mastectomies. I believe she had, I wasn't her doctor, so I don't know exactly, but I believe she had one cancer in one breast, and she chose to have both breasts removed.
Okay.
So those women that have a prophylactic mastectomy when they don't have BRCA1, now they only have about a 1% chance of developing contralateral breast cancer. So their risk of developing that other cancer is pretty small.
Sure.
And most of us in the field, in oncology, most of us have been fighting to save the breast. So in the old days, most women would have mastectomy for breast cancer. Today, most women can have lumpectomy, which is removing a little lump of cancer, and then we give a short course of radiation to the breast, and the results are identical.
Mm-hmm.
So women can keep the breast and have the same high chance of being cancer-free as a woman who had mastectomy. So for most women, there's no need for mastectomy.
Right.
And mastectomy isn't something magical. It doesn't buy you something that you can avoid. So I always believe, try to keep your body intact, try to avoid cutting and bleeding and amputation of your body parts if you can avoid it.
Certainly.
But it's a personal decision. Every woman has to make that decision. We've had, over the last few weeks, a lot of women come forth who have had masses in the breast and have been reluctant to see a doctor about the masses, and we urge those women to come in. It's easy to get checked out. It's easy to get diagnosed. If it's nothing, we can tell you it's nothing. If it's something, you can start treatment because you don't have to die of embarrassment. You should get treated, and I would urge women not to get embarrassed about a breast lump. This is something we do every day, and can be treated. Most breast cancer is cured.
Yeah, it's true.
We had some other interesting cases this week. We had a man who came back to us. He had a small cell cancer. So there's two basic types of lung cancer, and they're kind of grouped together: small cell and non-small cell. Non-small cell includes, do you know what they include?
Squamous cell carcinoma, and a few other ones. Yeah.
Adenocarcinoma, large cell cancer. So
Right.
small cell is distinct because more chemo is used than other treatments. This man came to us from out of state. He had chemo for his small cell cancer. He had one large mass in his lung. Came to us about 3 months ago, and we did radiosurgery because the chemo wasn't working.
Mm-hmm.
We made the non-invasive treatment. He had 5 treatments in 5 consecutive days. went home. He just came back for a PET scan, and the PET scan showed what we'd expect, and that is that the cancer has shrunken significantly in size.
You must be very happy.
Well, I'm happy because I'm happy for my patients, and the patient was happy too because he had a large mass and he had pain there, and the pain went away there. So that was a good case this week that we had. We had several people who came with acoustic neuromas, which are benign tumor of the eighth nerve. They're tumors that cause hearing loss and balance issues and sometimes ringing in the ears. And we've had a program for 20 years now. It's the largest program treating acoustic neuromas with fractionated radiosurgery. Radiosurgery means it's focused, and fractionate means we divide up the dose into a few treatments.
Right.
And we have excellent results. Anyway, we had two people call us. They had other treatments. One had a cyberknife treatment and was left with trigeminal neuralgia, which is not uncommon. We've had a lot of complications of people going elsewhere. Trigeminal neuralgia is from the trigeminal nerve. It's probably from the nerve being damaged.
The fifth nerve.
They're having tremendous facial pain. They were worried it's a recurrence of the tumor, which it probably is not. It's probably just a complication of the cyberknife, and that's why we tell people to get the best treatment. Sometimes the newest treatment isn't always the best treatment, and there's a lot of new machines, like we talked about the robot earlier this hour.
Yeah.
And there's always issues with doses and technology, and there's a lot of uncertainty with this equipment. So we urge people, again, to look around and think about what they're going to do before they actually do it, and look at the track record and speak to some of the former patients. So I think that's all very helpful.
Definitely. Let me remind listeners to just call in if they would like. The number here is 1-800-321-0710. And again, that's 1-800-321-0710. All
right, so we're at WOR studios today. Yesterday we're at ABC. Tonight we have a special guest on our program. We have another new, unique program tonight on WOR at 9 p.m. with Dr. Paul Olfett. Dr. Paul Olfett wrote a book called Do You Believe in Magic?
Mm-hmm.
And he's going to talk about vitamins, megavitamins. He's going to talk about antioxidants, vaccines, and other issues in healthcare.
Yeah.
And he's an incredible writer. You've heard him speak.
I have.
And hopefully it's going to be a great hour, and people will tune in. We have Dr. Eisen on the line. Dr. Eisen just called in. He is a radiation oncologist. He was born and raised in Argentina as a Spanish-speaking doctor. He went to Columbia, where he trained in radiation oncology, and he now works at Radiosurgery in New York, where he practices, and he's taking care of many, many Spanish-speaking people with cancer. So good morning, Dr. Eisen.
Good morning, Dr. Lederman.
How are you today?
Good, very good.
Buenos dias.
Buenos dias.
¿Qué pasa?
Well, very interesting program, and I have the same actual experience in patients sometimes with tumors that they really create a lot of pain. Patients with stage 4, and just 5 treatments with radiosurgery actually makes a huge difference on the quality of care.
So what's your experience in pain relief using radiosurgery?
It's actually very, very good. I mean, the patients immediately, very quickly, they achieve control on the pain. We start decreasing the pain medication, and we find other ways. I mean, sometimes we give a chance to the other team of doctors to be able to try maybe a different approach or try different chemotherapy, or sometimes surgeons, they have to review the case.
So when you, just hold on, so when you treat someone who has cancer pain, so the cancer's pushing on nerves or eating through the bone or doing something bad to the person, and then you offer radiosurgery, which is a non-invasive treatment, and what's the likelihood of the pain going away?
Pretty high. I mean, at times I almost surprised myself because the patients immediately after like maybe sometimes even 2 treatments or 3 treatments, already the decrease in the pain is very, very high. Sometimes even 50-60% of the pain start going under control. And the important thing is that sometimes these patients, they come in